Assalamu alaikum طلاب. I will start the discussion for pituitary gland disorder, the first lecture of today. As previously I told you, pituitary disorders are rare diseases, but for you to be doctors, you must know these points for academic purposes, but really they are rare diseases. It involves several endocrinal axes, so investigations and treatment also involves other glands. This means that pituitary gland, as I told you, it is a master gland. It controls other glands. So the treatment also, investigation and treatment involves other glands. Okay? So to be good in any subject, you must know an overview, not view, overview, which means only review, okay, of anatomy and physiology. A pituitary gland is enclosed in sella turcica, and it is bridged by dura diaphragma sella. Okay, there is a sphenoid sinus below, and the optic chiasm, it goes above it, or translated or passed above it. And we have cavernous sinus lateral to pituitary fossa, and we have the third and fourth and sixth cranial nerves. So imagine that how critical, very, very sensitive location. We have very important anatomical structures. Besides the cranial nerves, which I told you, the oculomotor, the trochlear, and the abducent, it's also related to the internal carotid artery. So the anatomical location is very sensitive. Pituitary gland got two lobes, anterior and posterior. It is held by an infundibular stalk. As previously probably I described to you, stalk mean a long stick-like. It got portal circulation to the medial eminence of the hypothalamus, while the posterior lobe, it is supplied or not supplied. The posterior lobe of the pituitary is not supplied by blood vessel, but controlled by nerves, okay, to the hypothalamus. Pituitary gland got two views on MRI, sagittal and coronal MRI view. This means that the best instrument or modality imaging for visualization of pituitary will be the MRI, okay? The second slide will classify the pituitary hypothalamus disorders. As you used to, I described to you in endocrinology, it is very important in classification to mention primary and secondary. Primary and secondary, to differentiate these, and investigations and treatment will be. So, previously also from probably the first the lecture I told you classification of applied in endocrinology, primary and secondary. And we have 5 sessions in the classification, whether we have the hormone excess or hormone deficiency, hormone resistance, or hormone hypersensitivity. The last one will be the non-functioning tumors. Here in this pituitary or hypothalamus, it is 4, because hypersensitivity we don't have, so 4. We will start by hormone excess anterior pituitary. The primary will be the prolactinoma, more common than the others. Then the acromegaly, then the Cushing syndrome. Part of the Cushing syndrome, which is due to pituitary disease, it is called Cushing disease, okay, due to microadenoma, you remember in the previous lecture. Then very rare disorders, the TSH-OMA, which means the thyroid stimulating hormone, adenoma, which is secreting the hormone. It is called TSH-OMA for abbreviation, like Fatouche. Okay, so this LHFSH-OMA, OMA, which means that an adenoma. So these are very important as a primary. As secondary, for hormone access, it is disconnection, hyperprolactinemia. Okay? Yeah. Disconnection, which means that when the pituitary is disconnected from its higher control, which is the hypothalamus normally secretes dopamine, which is inhibitory for prolactin. So when the stalk disconnected, I told you the stalk, pituitary, it got pituitary stalk, is disconnected, so there will be hyperprolactinemia. Okay, we will come to the hyperfunction of posterior pituitary and the hypothalamus. A primary cause for that will be SIADA. This at one time I told you SIADA. The SIADA is the syndrome of inappropriate IDH secretion, antidiuretic hormone. Okay, so this is for excess. We will come to that deficiency, hormone deficiency. In the anterior pituitary, we have panhypopituitarism. Which means that the whole pituitary gland is dysfunctioning, okay, or decrease in its function. As a secondary for that will be the growth hormone releasing hormone deficiency from the hypothalamus, and a very rare but interesting syndrome which is called Coleman syndrome. The man or the patient will be tall with diminished olfaction. So its diagnosis will not be so difficult. If you see a very increase in height, a tall man with decrease in the olfaction or the smelling, this is Coleman. For posterior pituitary, it is cranial DI. So, DI, I mean abbreviations, I will tell you. Diabetes insipidus, okay? Cranial DI, which means that we have two causes or two classes of diabetes insipidus, cranial or central and peripheral. Okay, we will come to that. Hormone resistance, this means that the hormone is plenty in amount, but it is due to some or other cause, deficiency of receptors, it will not work. Laroon dwarfism. This Laroon dwarfism, which means that the growth hormone is present and it is plenty but not acting. This Laroon is common in one of the African countries. Then most of the nations, they are dwarf. As I told you, in the peripheral cause for the diabetes insipidus, the receptors in the renal tubule are defective. So this is called peripheral diabetes insipidus. So by now you know two causes for diabetes insipidus, central and peripheral. The last class for tumors or for the disease of pituitary will be non-functioning tumors. Pituitary adenoma, most of it, as I mentioned, functioning, but sometimes they are non-functioning, or craniopharyngioma, also we'll discuss this later on, or metastasis. Imagine that this will be very, very rare. because imagine this, there is a tumor which metastasizes, and this metastasis go to the brain, and part of the brain is the pituitary, so it is very, very rare and very remote chance. The other slide, next slide, will be investigations of pituitary and hypothalamic disorders. So here also the class, all of these are in classes, because these diseases are, although rare, but very interesting and difficult for management and for investigation. So if we are facing hormone deficiency, which mean hormone deficiency of other glands, like in adrenal gland, we will do ACTH, short ACTH stimulation test, okay, then followed by long, okay, repeated doses. Then for the gonadotrophin, we will do LH, FSH randomly. We will estimate the serum testosterone. For premenopausal, one question will suffice. We will ask about the menstrual cycle. If it is regular, this means that the axis is perfect. For postmenopausal, we will order LH, FSH. Okay? For the thyroid, we will do TSH, random. It does not need dynamic. Okay? So we will do a random T4. Okay? And TSH, if it is normal, which is supposed to be low, if it is normal, this means that it is inactive form, okay? The TSH isomer, so TSH should be in the secondary low. In other diseases of the pituitary, these hormones will be low, while in primary conditions of the glands, the pituitary hormones will be high, okay? For growth hormone, we need stimulatory tests. I will describe that, okay, like post-exercise for growth hormone, or we do ITT, abbreviation, this for insulin tolerance test, okay. For cranial or central diabetes insipidus, which is manifested by polyuria, polydipsia, okay, this will be masked by presence of deficiency of ACTH, TSH. When you supply these for a case of secondary panhypopituitarism, this will appear after treating the patient with ACTH or TH. We must exclude here other causes of polyuria, because polyuria, not only DI. So for other causes of the polyuria and polydipsia, first will be the blood sugar, I mean diabetes, you know. Then we mentioned now the diabetes mellitus and diabetes insipidus. Then the hypokalemia, then hyperkalemia. These are among causes for polyuria and polydipsia. If we are suspecting DI, diabetes insipidus, the specific test will be water deprivation test. Nowadays, they are doing 5% saline infusion. This is different from ordinary saline, which is 0.9. Here, hypertonic saline. Okay? If we face hormone excess, we will do random prolactin level. If clinical features are suggestive, we'll do GTT, glucose tolerance test for acromegaly, which means that if you are suspecting acromegaly, okay, from the feature of enlargement of the hands, the head, the prognathism, we will describe that. We will load the patient with glucose, then we will do the growth hormone estimation, or we will estimate insulin-like growth factor, which is the IGF estimation. In Cushing disease, you remember in the previous session we will do dexamethasone suppression test, which a lot of suppressive tests, single dose dexamethasone, then small dose, then large dose dexamethasone suppression test to diagnose Cushing disease, which is not Cushing. Now we will come to the hormone excess, prolactin, random prolactin level. If clinical, I described this, we will go to, after diagnosing or suspecting the condition, we will go to the, establish the anatomy. What is establishment? What is going on? We will assess visual field testing, okay, in the visual VFT by sending the patient to ophthalmology department. It is called perimetry, or by imaging, MRI, CT, or during surgery we'll do biopsy by chromophobe, non-functioning, acidophile, prolactin, growth hormone, basophil. Now I will tell you the presentation here as far as a lot of classes. So we'll mention if we have 40 years younger, there will be secondary amenorrhea or galactorrhea and hyperprolactinemia. Because first there will be microadenoma, then it will change to macroadenoma. In postmenopausal or in men, the diagnosis will be at an early age, okay? Macroadenoma, there will be visual field defect. Or if we are facing the patient, we will face the patient an incidentoma by CT or MRI. If we come to the symptomatology of the above mentioned, either hormone deficiency, okay, the patient will be presented general. As I told you, general symptomatology, lethargy. Lethargy can be due to growth hormone deficiency. The patient will tell you that I feel fatigued and lethargic all the time, or part of the growth gonadotropin hormone deficiency. The patient also feel lethargy, but here with loss of libido, and hair loss and amenorrhea help you in localization or specifying the cause. In ACTH also there will be lethargy, but with hypotension, pallor, hair loss, and hypoadrenalism, which is secondary, not primary. In primary there will be hyperpigmentation, while in secondary there will be pallor. Also in hypothyroidism, if it is due to hypothyroidism, whether secondary or primary, the patient will feel lethargic. In ADH, antidiuretic hormone, especially in post-surgical patients, there will be lethargy because of loss of amount, a large amount of urine will be seen, so loss of electrolytes and water. The patient also will feel thirst, and there will be polyuria. So lethargy is a manifestation of many endocrinal disorders. We will go to the other associated features. In growth hormone, I will tell you associated with what other features of growth hormone disorder. Okay, in gonadotropin will be sexual features. In adrenalism, hypoadrenalism, the hypotension in the thyroid also, and Then we will come to local. That previous sector was general, applies to most of the gland parts of the gland, which is the pituitary. Here, local. For pituitary, because it is located in this very sensitive and critical area, of course, there will be headache. A headache due to pituitary disorder, due to increase in the pressure inside the brain, so there will be a severe headache, or visual field defect, bitemporal hemianopia. At one time, I told you, the patient will lose the ability to see both lateral sides of the visual defect due to affection or defect in the chiasm. Then there will be disconnection, hyperprolactinemia. Then the diplopia, because there will be an insult to the cranial, three important cranial nerves, which is the third oculomotor, the fourth the trochlear, and the sixth abducens. There will be diplopia when there is involvement of the cavernous sinus. Then if there is a picture of acute infarction. Here, infarction, it is not only infarction of the heart, also pituitary got infarction. It is called apoplexy. Remind yourself about this term, new term for you. Apoplexy is infarction of the pituitary. This is due to when there will be a rapid expansion in pregnancy and the pituitary gland is subjected to an ischemia due to labor problems. It is called Sheehan syndrome. The hormone excess features due to hyperprolactinemia. There will be galactorrhea, amenorrhea, and hypogonadism. Okay, this will be very important. Acromegaly, there will be, of course, headache, increased sweating, change in shoe size. The patient would tell you that I am in need of changing my shoe frequently, or the ring, the marriage ring, or the other rings, as this used by many of you, and the ring it becomes smaller and smaller. Or in European countries, those using heart, the heart size will need to be increased. This is very important to inquire. Then in cushion disease, we will ask about weight excess, because it will be causes of obesity. Bruising, I told you in the previous lecture, amenability or susceptibility to bleeding under the skin. Myopathy, proximal myopathy. The patient will tell you that when I sit, I cannot stand. Or there will be hypertension, secondary causes for hypertension, or stria, abdominal stria, or stria on the thigh. Characteristically, it will be pinkish, or the patient will present to you as depression. So keep in your mind the features of the pituitary gland. It is not one or two or three. It depends on which part of the gland. Then next slide will be etiology of anterior pituitary deficiency. Structural, first, tumors, adenoma, or craniopharyngioma, or as I told you, hemorrhage, apoplexy. Or it can be due to inflammatory infiltration, inflammatory and infiltration, like in sarcoidosis, by granuloma, TB, infection by tuberculosis, or it may be congenital, okay, as we mentioned, the gonadotrophin releasing hormone, Coleman syndrome, or there will be TRH, the thyroid releasing hormone, or the corticotrophic hormone releasing factor. Okay, functional, which mean that the function of the pituitary gland is affected by chronic systemic illness. Like in anorexia nervosa, this is a psychiatric disorder. The patient attempts at dieting, okay? Or by excessive exercise, ladies who are involved in gymnastic or in marathon, okay? Others, by head injury, post-surgery, radiotherapy for the head, for cranium, or postpartum necrosis. Sorry, I told you this is the second time we are mentioning this Sheehan. Sheehan syndrome is a very important and interesting. Then we will come for the next slide, test for growth hormone secretion. Here it is very important to mention that not done except in certain circumstances. The growth hormone not to be estimated randomly. It should be during sleep, 1 hour after going to sleep. We need here frequent sampling, or we will order the patient to do exercise, okay, post-exercise, okay, or insulin tolerance test. We will induce hypoglycemia to the patient. We'll describe this later. Or we will give this amino acid arginine, okay, or using antihypertensive, an old one, clonidine. So we have 5. Now we will describe a famous test, which is insulin tolerance test, but not applied in every center. Mostly it is applied in specialized endocrinal centers. This insulin, because we will give insulin to induce hypoglycemia. It is very serious and critical test. This in hypoglycemia, we will assess the HIPAA. What is HIPAA? The hypothalamic pituitary axis. Okay? If other tests are not confirmative, as I told you, it should be done in specialized centers, especially in pediatric age group, to know or to work up for short stature. The IV glucose should be ready, okay? Hydrocortisone. Hydrocortisone and glucose should be ready for resuscitation in event of some complications. We must know the contraindications for the test. It is not easy to induce hypoglycemia in every patient. So contraindications will be in adulthood, presence of ischemic heart disease or epilepsy. If the patient got fit, so there will be induction of fit by hypoglycemia, or we are afraid of severe hypopituitarism crisis. The dose of the soluble insulin should be calculated by 0.1 unit per kg, and the blood sugar to be decreased to less than 40. So the blood sugar should be decreased to less than 40 milligram deciliter, and we need 6 samples. Here it is very important, not like the other tests, 6 samples. Sample 1 during 0 time, then 30 minutes, then 45 minutes, then 60 minutes, then after 90 minutes, then 120, which means 2 hours. We will check the growth hormone and the cortisol level. So if I tell you, tell me in brief, what is this insulin tolerance test? Okay, it is different from glucose tolerance test. Glucose tolerance test, we will load the patient with glucose. Here, the reverse, you will give insulin and you will create hypoglycemia, okay? After diagnosis of the condition of the hypopituitarism or pituitary dysfunction, it is very important and the easiest. So the features, clinical features, are very difficult. The approach to the patient, very, very difficult. But the treatment is very easy. Easily mentioned is replacement of the hormone which is deficient. First, it should be noted by you, thyroid hormone or thyroxine should not be replaced first, because if you give thyroid and there is underlying hypoadrenalism, you will create crisis. Okay, this is very important. So hydrocortisone should be replaced first. This is an important point to be known. Then, after giving the hydrocortisone or the thyroid, second, then I will give the growth hormone if the patient is below 18 years for completing the height of the patient, or later on for well-being of the patient, okay? Then in premenopausal, sex hormones for the female and for the male, pre and post, according to the will of the patient, needs sexual activity, and we will replace the antidiuretic hormone. So the replacement is very easy. Consists of 5 hormones: the steroid first, the thyroid second, the growth hormone, then the sex hormones, then the antidiuretic hormone, vasopressin. Okay?